Thank you for that introduction. I'm excited to spend the next quarter of an hour parsing out what is known about HIV pre-exposure prophylaxis, or PrEP pharmacology, in this extremely vulnerable and relatively understudied population of transgender women. And while this ever-growing body of data is beginning to paint a more complete clinical picture, I think I most urgently want to impress upon you that parts of this story are still being written, and to leave the field with a call to action for more rigorous pharmacologic investigation to guide the next steps that will be necessary to abate the impact of HIV within this community of women. I have no conflicts of interest to disclose. Transgender women have been disproportionately impacted by the HIV epidemic. Recent CDC surveillance data from 7 US cities demonstrates the full weight of this statement, with prevalence estimates of up to 62% among the most vulnerable transgender women. Yet their enrollment into PrEP clinical trials has been challenged for a host of social and economical factors. Of the approximately 13,000 study participants enrolled into 3 randomized clinical PrEP trials that were inclusive of this population, less than 8% reported transgender identity or used a gender-affirming hormone. Most disappointingly, study investigators have discovered, which was a non-inferiority trial to test daily oral emtricitabine with tenofovir alafenamide, or FTAF, against daily oral emtricitabine with tenofovir disoproxil fumarate, or FTDF, only succeeded in enrolling 1% of their study sample from this high-risk population. While this underrepresentation creates challenges in conducting rigorous subgroup analyses, higher HIV incidence among transgender study participants taking PrEP are cause for further exploration. Here I'm showing subgroup incidence data from the HBTN 083 study, which was a non-inferiority trial of a long-acting injectable of cabotegravir versus daily oral FTDF. And HIV incidence across these 2 arms was 39 to 58% higher among transgender women when compared to cisgender men who have sex with men. Subgroup analyses from the IPREX trial, which was a placebo-controlled trial to test the efficacy of daily oral FTDF, also demonstrate similar trends of higher incidence among transgender women. Interestingly, IPREX investigators also observed lower tenofovir diphosphate concentrations in DBS samples, which were randomly collected throughout the trial to measure adherence. These data are shown here in the top left graph as concentration on the y-axis, and in the bottom left graph as the proportion above a concentration threshold that has been associated with protective adherence in cisgender men who have sex with men. In these graphs, transgender women taking gender-affirming hormones are represented by the light pink lines, versus cisgender men who have sex with men in dark blue. You can see that throughout the study, less than 10% of transgender women on gender-affirming hormones exhibited a DBS measurement associated with protective adherence. These data were then fit to a regression model to try and understand PrEP efficacy as it relates to adherence in transgender women. And while the average model predictions for these 2 subgroups, which are represented by the solid lines, are mostly aligned, the degree of uncertainty in the prediction for transgender women implies that even among transgender women with DBS measurements suggestive of complete adherence to daily dosing, some level of breakthrough infections might be expected. Begging the question, is the driver of higher incidence in PrEP clinical trials really just behavioral, or might biology also be a contributing factor? From limited study, we know that estradiol concentrations in transgender women taking gender-affirming hormones are within the range of those observed during the late follicular phase of the female reproductive cycle, when estrogen peaks, and during the first trimester of pregnancy. We also know that female sex steroid hormones impact physiologic processes involved in drug disposition, including decreasing intravascular volume and increasing sodium and water retention, which can lead to an increased volume of distribution for hydrophilic compounds like tenofovir and emtricitabine. So what do these potential changes in ADME processes mean for systemic PrEP exposure? Across multiple small observational cohort studies, we've seen lower plasma tenofovir concentrations in transgender women when compared to cisgender populations. Here I'm showing concentration versus time data from 2 representative clinical studies. On the graph on the left, 8 transgender women taking gender-affirming hormones are represented by closed circles, and 8 cisgender men who have sex with men are represented by closed squares. They participated in a directly observed dosing PK study of FTDF, and the trough concentrations observed in transgender women were significantly lower. On the right, plasma tenofovir concentrations following daily FTDF is represented for 15 transgender women as open circles and 17 cisgender male or female adults as closed circles. And in this study, AUC was significantly lower for transgender women. Well, these data are interesting and might be attributable to gender-affirming hormone-mediated changes in volume of distribution or renal clearance. The degree to which these small changes in exposure of the tenofovir prodrug might impact efficacy is still uncertain. And a more complete assessment required digging further into the intracellular pharmacology of oral PrEP. Tenofovir alafenamide and tenofovir disoproxil fumarate are prodrugs of the monophosphate nucleoside analog, tenofovir. Both tenofovir and emtricitabine are intracellularly phosphorylated to their active components through a series of phosphate additions mediated by kinase enzymes. Conversely, intracellular phosphatase enzymes can remove these phosphate groups. The final nucleotide analog, tenofovir diphosphate and emtricitabine triphosphate, compete with the host cell's natural deoxynucleotide pools for incorporation into the growing HIV DNA strand by reverse transcriptase. Tenofovir diphosphate gets incorporated in the place of deoxyadenosine triphosphate and emtricitabine triphosphate in the place of deoxycytidine triphosphate. Once incorporated, no additional nucleotides can be added, which blocks completion of the HIV DNA strand prior to integration. So what are the implications of female sex steroid hormones on pathways that activate, i.e. kinases, and deactivate, i.e. phosphatases, also known as nucleotidases, PrEP? Here I'm showing data from a study where a panel of kinases known to activate tenofovir were interrogated in the blood and colorectal tissue of transgender women and cisgender men who have sex with men. No difference was observed between the groups, indicating that female sex hormones likely do not alter PrEP's activation. But what about deactivation? In vitro data show that high doses of estrogen can increase nucleotidase activity, demonstrated in the upper right graph, among cells that were isolated from tissue collected from the endometrium, ectocervix, and endocervix of women, and then treated ex vivo with estradiol. Induction of these phosphatase enzymes is indicated by a fold change in activity across all replicates of greater than 1. Additionally, when female genital tract derived CD4 cells are treated with estrogen, progesterone, and tenofovir, we see lower amounts of the active metabolite, suggesting higher degradation rates. These data are shown on the bottom left graph, with tenofovir diphosphate concentrations reported as percent of control on the y-axis and the various treatments on the x-axis. Interestingly, we do not see this same difference in identically treated blood-derived CD4 cells, which is in the bottom right graph, suggesting that the hormone receptors may be augmented in the tissues and cells may be more responsive to these hormones, depending on where they come from in the body. Given the potential mechanism, much effort has gone into exploring whether tenofovir diphosphate and emtricitabine triphosphate are altered in transgender women. In the Discover trial, PBMC data were used to assess for an interaction. These are categorized for transgender women versus cisgender men on the x-axis, with tenofovir diphosphate, top graphs, or emtricitabine triphosphate, bottom graphs, on the y-axis. The left graphs are observations from participants who were randomized to take FTAF for PrEP, and the right are FTDF. The Discover trial demonstrated no difference in PBMC concentrations between these participant subgroups for either tenofovir diphosphate or emtricitabine triphosphate. Yet PBMC data from a directly observed therapy study in transgender adolescents complicates the picture some. While they found that both tenofovir diphosphate, y-axis on the far left graph, and emtricitabine triphosphate, middle y-axis, concentrations mostly overlapped previously published ranges from directly observed therapy PK studies, which are denoted by the gray shaded regions. They observed significantly decreased concentrations within their study samples among transgender women that used intramuscularly administered estradiol versus oral or sublingual estradiol. These women are depicted by the closed purple circles versus those using the oral route of administration in the open purple circles. Interestingly, in this study, IM administration was also associated with an approximately 30-fold increase in plasma estradiol AUC, which is the right y-axis, when compared to oral administration, which might imply that a correlation between plasma estradiol and PBMC tenofovir diphosphate and emtricitabine triphosphate measurements exists. While these PBMC data are important, a multitude of work shows that blood concentrations don't always correlate with transmission site tissues. Additionally, estrogen concentrations within breast tissue are known to be considerably higher than the blood, but haven't been studied in other tissue sites. And finally, while estrogen receptor is known to be differentially expressed within different anatomical sites, its level of expression on CD4 cells in the lower gastrointestinal tract has not been studied. To date, two very small observational cohort studies have reported differences in PrEP pharmacology within the lower gastrointestinal tract. These differences are shown in the table on the left for a cohort study that I described earlier, where rectal biopsies were collected from transgender women and cisgender men who have sex with men. Colon cells isolated from these biopsies demonstrated a non-statistically significant trend towards lower concentrations of the active metabolites. The graph on the right depicts data from a clinical study that was conducted at UNC comparing transgender women to cisgender men and postmenopausal cisgender women. On the y-axis, PrEP's active metabolite concentrations have been normalized to their respective competing endogenous nucleotides, which have been shown to impact potency. PBMCs are in the top panels and homogenized rectal tissues in the bottom. While we saw no differences in PBMCs, we observed a 7-fold decrease in the rectal tenofovir diphosphate to DHP ratio of transgender women. So with those final data in mind, let me leave you with some conclusions and future directions. First, transgender women have been underrepresented in HIV PrEP randomized controlled trials, impeding our ability to fully understand PrEP effectiveness in this population. However, the higher HIV incidence among transgender women in these studies suggests reduced effectiveness that could be attributed to adherence barriers or pharmacologic differences. Second, gender-affirming care has the potential to alter ADME processes, as well as intracellular enzymatic activity that could shift the PrEP PK-PD relationship, providing a possible mechanism of reduced effectiveness. Third, while clinical data suggests that estradiol reduces PrEP's active metabolites in PBMCs of transgender women, the degree of change may be clinically insignificant. And finally, data within HIV transmission sites in transgender women is extremely limited, but suggestive of decreased PrEP exposure. These data demonstrate the need for further investigation in larger, more intentionally designed clinical studies. With that, I'd like to acknowledge our amazing CPAC team for all their contributions within this field, and an excellent team of external collaborators who have been going to heroic efforts throughout the pandemic to conduct a clinical study designed to address some of the knowledge gaps highlighted throughout the presentation. Thank you for your attention.